Hello, everybody. My name is Hugh Shoff, and I am the Assistant Dean for Quality and Patient Safety, as well as the Associate Chief Medical Officer for University of Louisville Hospital and emergency medicine physician. So thanks for being here today and for being part of the discussion. We're going to go over a few things today around quality and patient safety, around how the GME is involved in that, and some other kind of tidbits here and there, just to give you an update on what's been going on, and also to assist you in understanding how this component of the GME and resident and fellow education is kind of wrapping in, and what things we are going and developing down the road. So with that, we'll go on to our kind of presentation. This is kind of a brief overview of the objectives today. We might not get to all of them, and that's okay, or we might blow through them all, depending on how many questions you might have or discussion. But we're going to review a little bit about the quality and safety common program requirements, the key things that we must do as programs to meet the requirements of the ACU GME for all of our residents and fellows. Talk about our IHI curriculum and certificate. Talk a little bit about the new adverse event reporting system that is at University of Louisville Health, specific to U of L Health, so that all the programs have an understanding of what is going on in our and kind of the changes that are happening. We'll talk a little bit about our collaboration that we're doing with the ACGME around safety event analysis. Talk about some health disparities, pretty hot topic right now. And kind of what guidelines and guidance the ACGME has around that. Talk a little bit about some new program about how we can get residents' feedback and evaluations on a more timely manner, easier, quickly, so that residents and fellows can get more feedback, as well as the faculty and educators can give that to them in a more quick, succinct manner. And then talk a little bit about clear visit that might come up, and how we can start talking about and having conversations around that, what that might look like and mean going forward. If you do end up having any questions, by all means, please, you can type them in the chat, and I'll address them as they come. I have keeping an eye on it, or we can just have an open discussion at the end. So with that going forward, we're going to start talking about some common program requirements. This is kind of an update and a refresher. I know I've spoken about this before a couple of years ago. This is to give all the programs an idea for you on the call around what is required from the ACU GME around patient safety and quality improvement, all the kind of the musts and shoulds. And I really kind of distilled it down into the big key areas that I know that the ACU GME is looking at, as well as the RRCs, so that you in your minds can start thinking about, are we addressing these, or how can we address some of these? So the big ones from a patient, it's divided into two categories. There's patient safety and quality improvement, and so they're the two different areas. And really, if kind of the patient safety aspect of this is going to be around events, adverse events. How do we approach those? How do we assess those, and as programs and as an institution? And then quality improvement revolves more around how are we using improvement methodologies, how are residents and fellows and faculty involved in quality improvement projects to involve the processes around this, those sorts of things. So to walk through these a little bit, key requirements in patient safety, and I'm going to separate these out and show you kind of how we are addressing those as a whole, and how you can convey to your residents and fellows that we are doing things around these. The institution must provide formal educational activities that promote patient safety related goals, tools, and techniques. The residents and fellows must understand, know how to, and be provided data around safety reports. This is our safety reporting, and we'll talk about that here in a second. They must participate as team members in real or simulated safety activities. Now, these can be RCAs, these can be deep dives, they can be the 5 whys around a project or a patient case or something that happened. They must have participation in something along those lines within the institution or within the program. And they must have training on how to disclose adverse events. So residents and fellows must have some sort of training around actual disclosure of events to patients or those that they're taking care of. So let's start looking into a couple of these and see what opportunities we have and what things we have available to help meet these. So first of all, I hope everybody's aware, but there is the IHI modules. This was instituted a few years ago and is, must say, is a requirement from from our GME that the residents and fellows do complete these. These are the IHI modules, been around for a while now. This meets that goal of educational activities and education around patient safety, as well as it meets that must have some training in disclosure of adverse events. This encompasses in that basic certificate on the IHI modules. The residents, some programs do it one way, other programs do it a completely different way. Some programs divide it up over the course of a year for the interns. Other programs say, here, go at it and finish all the modules and just make sure you get us your certificate. But just to remind everyone, this is a requirement. And I know I mentioned it at the GME meeting, but we will be getting you your percentage, your program percentage out to you so you know how many of your residents and fellows have completed these. But there are 17 programs out there without any completion. You see 16, another 32 somewhere in the middle, and then 11 programs that have 100% completion. So remember, this is that base education, and this meets the objective of education in patient safety as well as education in quality improvement methodologies. It gives you both sides of that. So for when the residents get that exposure, they now have the ability to have those discussions around patient safety and quality improvement that we want them to have and to be a part of that system process. They also have a module on how to disclose adverse events. And then you can even go so far as going past the certificate into some more deeper areas around the modules. And there's some good ones, how to be a leader, how to do some other things, how to be more advanced in quality improvement. So if you come across a resident or fellow or trainee that has some specific interest in this, by all means, encourage them to go on or encourage them to learn more. There are a good number of medical students that are now coming in and to our programs that have done this in medical school, because there's a good number of medical schools out there that are adding this into their curriculum because it's becoming more and more it's permeating more and more of the educational system from the medical education all the way up. And so some residents or some medical students might already have them. Just ask them to provide their certificate and you can upload that. But for those that haven't, those modules, and if you need assistance in that, you can reach out to Laura, Cherie, or myself in just getting that information and how to do that to your residents and fellows, the trainees. So when we look at our educational component of this, this is where we meet that kind of goal. This is how we're addressing some of that in this IHI modules. So let's go into the next one, incident reporting. All trainees, and I want faculty too, need to know how to report an adverse event. This is key to our healthcare system. It's key to an educational component for the residents and fellows. It enables people to better recognize adverse events or near misses and to be able to report those, which helps the institution know where things are happening. And so what do you report? And it's really any event or circumstance that resulted or did result in unnecessary harm to a patient. Key thing here is that does not have to be an active event. If it's a near miss, most times we can learn a lot more from near misses in the sense of preventing a harm down the road if we can know about those near misses. So say a medication makes it all the way up to pharmacy and all the way up to a patient, almost gets in and the resident notes it and says, hey, wait a minute, that's the wrong medication. That's a near miss. Let's get that reported so we can figure out where the breakdown happened in our process. So all reports should be entered. I would encourage your programs to make sure at some point along the curriculum that we every year, every twice a year even reiterate to the trainees, hey, this is how you report event. Make sure you're reporting events. This is a big part of what we need to do. And it's not only just to patients, it can be related to visitors and staff. It can be related to anybody within our health system that something happens to needs to be reported. And so for the programs, for the training and what the ACGME wants to say is when they come down and they come do the site visit, they're going to ask the residents, do you know how to report an adverse event? Do you know what you need to report? And they need to be able to say, yes, I know how to do this. This is our system, etc. And so we just switched from, it was PSNs, we switched to a new program in December called RL Solutions. The reason being is it offered us a much easier interface. With Cerner, it allowed for patient information to be automatically populated so that it was easier to do. That was one of the big feedbacks I got from the residents in the programs, was it's really not easy to do a PSN. And so we're hoping that this system enables it to be much easier, much more intuitive. Plus, the system allows us to collect a lot more in-depth data on the back end and about what's going on, keep track of these events so that we know what RCAs have happened, what work is being done to prevent or improve the process behind it. And that goes to meet that other category of this in the common program requirements is the residents must get feedback on or reports on the safety events. And I'll go into that here in a minute, but just so everybody here knows about how to do this, I'm hoping that this is a conveyance for information to come down from here to you into your programs. But there's 3 locations for RL Solutions to find it in the hospital. And now this is U of L Health specific. This is going to be Jewish, Mary Elizabeth here. I'm sorry, here, meaning U of L Hospital. This is not VA or Norton. They both have their own systems as well. But in the big scope of things, at the main training institute or site, for instance, in a clear visit or for instance, RRC visit, they're going to be looking at, do they know how to do it here? Now, for the pediatric residents, of course, they have a different process over at Norton, but they, being aware of that. But anyway, 3 locations you can find that desktop. There's an icon on the desktops when you're in the hospital. If you're in Cerner in the patient's chart, there's a link to it in the chart up at the bar at the top. And then you can use the U of L hospital intranet. Full transparency, I have no clue how to get into the intranet here. I probably should, but I have no idea, so I probably would not worry about that one. I would worry more that the 2 options that you can get are the desktop and the patient's chart. And once you're in it, you can go in, you can log in with your username and password that you would use at U of L for logging into Cerner. But really, or you can do it anonymously, either way. The difficult part about anonymously is going to be getting feedback to a specific person. But as long as in the report they're indicating maybe an area or a service line or something like that, then we can tabulate that data and get it back to you. So it's okay to do it anonymously, but the caveat being that you might not get individualized feedback on it. So that's the only downside. But we want to be able to give people the opportunity that want to. Once you get into it, you just click a new file. It's like new report, and then it looks like an iPhone here, right, or your phone. It's very kind of picturesque in the sense of, pretty clear in a way of figuring out what you want to report. Is it an imaging thing, a lab problem? We have this big aggressive patient face. We use that in the ED a lot. Let's see what else. Infection, surgery or procedure, etc. And as you can see, you just click on one and it walks you through the process of getting that reporting. The big things I want to emphasize here, and I put this up here this is from the training for RL Solutions, but this great catch button, this is where the near misses come in. And when you talk to your residents or your trainees, either on round service or in the department, near misses, I think, are very important to me. They allow us to understand a lot more. And I think the residents need to learn that. The ACGME likes to know that near misses are a key component of safety reporting. When I've been in meetings with them, with ACGME and such, the caveat always is, are you not only looking at events, but are you also looking at near misses and great catches? So this button allows you to report those. And then we have some other staff conduct. This is our most frequently used button because people like to complain about each other. But otherwise, kind of emphasize those near misses. And then the other nice thing about RL that you can tell the trainees is that it self-populates the data. So you can look up the patient, you can look up the patient's name, and it will pull in that patient information into the report. You're no longer having to type all that in. It's nice and easy, kind of upfront as much as possible. So just to reiterate to everybody, remember events are improving patient safety, reporting is improving patient safety. This is a key component of our training in our hospital system. That it's not disciplinary at all. I tell everybody that 99.9% of errors are not on purpose, right? Nobody comes to the hospital in the morning and says, I'm going to do something to cause harm today. Um, there are instances of that, yes. That is a totally different pathway. But I just want to reiterate to everybody that reporting does not mean discipline. It means the opportunity to improve. And so please encourage reporting to your trainees and how to do that. Feedback will come. We are working on how to tabulate that data and get it to the programs specifically or to that person that reported it. We will do event analyses on all the significant reports that get or events that get put in. That information comes down through MEC and a couple other pathways. And then medication errors and things like that, CAUTIs, collapses, all those things that we worry about comes through too. So the more we report those, the more you see the data change on the back end. So that's a lot of that feedback. So it might not be a specific email to the resident, although I want to do this, but right now it might not be that says, thank you for the report, this is what we've done, this is how we're working on it, etc. RL is going to allow us to do that eventually. But in the sense of residents understanding that some of that feedback mechanism might come from data reporting or improvement in our scores or data on the back end. So that's kind of how we're addressing safety reporting here, how you can tell your residents in the RRCs, or if the visit comes, how that is being done at the main training site here at university. And if we reporting really does reduce. So if we don't report, it reduces our ability to quantify the risk, and we only put resources towards what we know, and we don't put resources towards what we don't know. So by reporting, it helps us do that. And I tell residents all the time, and an understanding of what is the barrier. So for our faculty and staff, what really is the barrier to reporting? A lot of times it's just time, how to do it, and worry about disciplinary action. But on this fishbone diagram, I use this a lot. Forms are too complex, and the process is too complex. I'm scared to do it. I don't want to report something that happened in the OR because my attending will be mad at me. Those sort of things we got to break down and build this culture back up of rewarding reporting. And that's where I think a lot of us can help in that in our programs in developing that. So again, report all adverse events. This is something I always am afraid of. It gets sometimes reported a lot. We kind of become complacent if we don't know something's happening. For instance, at university, we haven't had a central line infection since April of last year. So we're going close to a year. But every time that gets announced, I always cringe a little bit because I worry that people are going to let their guard down, and it's going to happen. But, reporting helps us prevent that a little bit and keep our guard up and aware. So that's my plug for safety reporting. Plus, when it comes to common program requirements, it's definitely a clear, delineated thing that the residents and fellows and trainees need to know how to do. All right, so moving on into the next common program requirement in patient safety is the must participate as team members in real or simulated safety activities, RCAs. Now, I know a lot of the programs, I know a lot of you out there do an M&M case, or you do your case reviews, in which case, a lot of times you ask all the questions that you would ask in an RCA, or you ask 5 whys. Why did this happen? What happened? What was the decision-making process, etc. And as long as you were drilling down to a problem or a process issue in those, so say you're in a surgical case and you find out, well, it was delayed because we didn't have a piece of equipment. Well, why didn't we have that piece of equipment, et cetera, et cetera. And if you give that feedback, you are doing safety activities within your departments. And I think some of this might be just conveying to the residents and the trainees that, hey, when we do these case reviews or when we do this and we talk about the processes around them, we are doing pretty much a 5 whys activity, or it's not root cause analysis because there's some formal structure around that, but you really are asking questions that deep dive into a case or a process, and that's what we want to be doing. To bolster this and to try and get our institution more on the innovative side of things, the GME, our Quality and Safety Subcommittee, submitted a year ago, now a little over a year ago, to be a part of this collaborative with the ACGME around getting residents and trainees more involved in root cause analysis with the hospital. The ACGME is starting to push in patient safety and quality improvement, is starting to push more integration with GME and the patient safety office of the institutions. They want to see more of the work being done together because they come to the awareness that our trainees really are doing a lot of that work and understand a lot of the process in the hospital in pretty finite detail within their realm. And so part of this collaboration was to work on an innovative way of getting residents more involved in the safety office, in the safety activities of the hospital. I think for a good thing. I know that a lot of times I get the kind of the argument back that, well, hey, we're asking the trainees to do all this work already. We're kind of bypassing the whole core curriculum to add on things on top of this. And to my response to that is, yes, there is a lot that we're adding, and time is finite, right? So, but I think, in my opinion, and this is just of course my own bias, patient safety, I think our residents and trainees are seeing a lot of things happen and are experiencing a lot of things, and in their heads they think, well, we could change this or improve this by doing this, because they don't have the kind of barrier of 10 years or 15 years of doing it the same way all the time. They have fresh eyes on a new process. And so if I can get that vision and that information from them integrated into our safety office to where we're trying to improve and putting resources towards, I think it's a really great opportunity. And so that's where I think that this is a worthwhile endeavor. So University of Louisville, we applied and became part of this collaborative in which it was looking at innovative ways of getting residents and fellows involved in safety event analysis. We called it RARE, Risk Assessment and Resident Education, because it was rare before. And when I looked that up, the only two things I could find is some song by Selena Gomez that I don't know. I only have a 5-year-old girl, so I'm sure one day I'll keep up and catch up with all of that. Or Rare Meat. So I really couldn't find anything that was pertinent to education around RARE. But you got to lighten up a presentation a little bit. So I guess there is a song. When I looked up RARE, it was page after page of Selena Gomez, and I am out of touch. So we called it RARE. And this is kind of what we're coming up with in our innovative way of pathway. The members of the subcommittee have been working on this for a while now. And what we would start to looking to implement is kind of two pathways. One is for larger programs. This is a way that we were hoping to get, for instance, larger programs such as surgery or medicine and some of those, to provide them the tools to do a kind of an RCA. And then provide them from the quality office cases that come through from the event reporting, and provide them with the tools that are needed to do this within their department. So say you take 30 minutes of a day or your of an opportunity at some point during a conference, and you say, okay, we're doing this RCA around this event. You pull in residents. It's great if it's interdisciplinary. It's even greater if it's interprofessional. If you can pull in nursing or pharmacy. I know pharmacy is always invited to the ED conferences and things. If you can pull them into the discussion, now you have a nice, robust input discussion around a case. We provide the cases from the quality department. You do the RCA, and then whatever you might find from a process issue, you feed that back to the quality office, and that gives us that feedback. And we were hoping that this could, like with some of the larger programs, this could be kind of a part, and that's your quality improvement, that's your patient safety activity. The faculty could be involved, that sort of thing, to bring that all together. When it comes to the smaller programs, we understand that they, resources or something like that, or just having a couple people, it might not be as easy. And so the quality office at University Hospital already has a process called a core team in which they look at some of these significant events that come through. And what we were looking to do from there would be to invite some of those residents to those meetings and have them participate in them and have them become part of the discussion. That way they can bring some of their ideas and thoughts to it. And that feedback comes directly into the quality office from there. And then from all that kind of robust discussion, we give the residents back feedback on how was the discussion, how was it performed, are there process changes? And then with this system, when the residents are asked, by RRC or by ACGB or by whomever, are you part of RCAs? Are you part of the hospital's quality structure? Do you understand the mission of the hospital? They can all say yes, or they can say, yes, I've been through this. Right now, this program, this is kind of early. We're still working in this direction to go in this direction. Every institution as part of this collaborative was all sidebarred by COVID, of course. And so every time we have a meeting, a lot of these institutions are saying, hey, we've got something in place, but we're working towards it. And we're going to do the same. And I think we're going to push towards some form of this. But this was kind of the overall idea that we had around this, and making it easier for programs to provide this experience and education to the residents. So with that, if you have questions at all, I'm just kind of rambling on here, throw them in the comments box, happy to answer them. But that kind of wraps up the patient safety common program requirements. The next ones we move into are quality improvement, common program requirements, and some things around quality improvement. So these are the three big ones kind of distilled down. They must receive training and experience in QI improvement processes, including healthcare disparities, must receive data on quality metric and benchmarks related to their populations, and must have the opportunity to participate in interprofessional QI activities. And this should include some activities around healthcare disparities. So we'll talk about these things. Again, we talked about the IHI modules. It gives that kind of base knowledge around QI improvement methodologies. Gives a little bit around healthcare disparities. I know there's a lot of work around this healthcare disparities now too, and some other educational opportunities around that, but that is out there. The next big one, and I know that's on us as a hospital, and I've talked to the CMOs about this, is about getting data back to the residents around their patient populations. And so there is quality metrics and benchmarks related to them. And right now it's pretty easy to get more of an umbrella kind of data, and I'll talk about that on the next slide, but it's easy to get that institution-wide kind of data back. But how do we just get that down into the specific populations that the residents are dealing with? And so I put them up, these three people up here. Dr. Krishnan at the VA is kind of the point person a little bit with around quality and safety and around some of that work. So if you're looking for VA specific data, that's a good person to reach out to. If you're looking for Jewish hospital specific data, Crystal Heichman is there. And then ULH quality is Regina Doan. And I put them up there because they are point people within the quality departments to, if you have something specific you're looking at, if we have it, we'll get it to you. When we look at what currently is available, so right now, so say we have a clear visit tomorrow, or your RRC comes for your site visit or something like that, what data is available to your programs and residents now? And so I kind of put this up there a little bit. We're part of Vizient, which is our quality database, where all the data is collected. That data is more of an overview, but we can drill down in some service lines for that. It goes over mortality, length of stay, patient safety indicators, patient satisfaction. That data is presented in multiple different areas. It's presented at the medical exec committee, the board meetings. It's presented at the resident quality and leadership council meeting. It's data that is put out there for people to see, to understand what is important to the hospital and how, and what are our big metrics that we follow. We can drill down, like for instance, length of stay, we can get down into more of a service line. So if you were looking at length of stay, the hard part about this though is drilling down into, first of all, getting the information down to that specific level, and next, getting it based on patient populations for healthcare disparity information. So I think we can get data around that, but if you're starting to look at healthcare disparities in getting that distilled out, it's pretty difficult to do. it's not, and we're not the only ones. When you look at the CLEAR report around healthcare disparities, almost all the institutions they visited had some difficulty in getting this information and drilling down into it. But the ACGME is going to continue to push, and I think we need to continue to do so as well, in figuring out what the data looks like and ensure that we are meeting the expectations across all patient populations we serve. There are some departmental specific data that is given to each department. It's around the hospital incentive goals. So if your department, whoever your service chief or medical director might be, does have goals within the department, and they do get data around those. For instance, in the emergency department, we're doing sepsis. I'd have to talk to Dr. Ross, I think, because it changed patient satisfaction and I think door-to-doctor time. But that's information you can provide to the residents and fellows and say, hey, this is information on how we're doing. And then you can even get some project-specific data. So around sepsis work or patient experience work. If there's a project going on around or that involves your service, we can work to get you that data. So there's opportunities to get some of that information to the residents and get some of that data to them. And so just if you need it or you need more specifics about that, you can reach out to these people for location-specific data, or by all means, please reach out to me, and we'll do everything we can to get you kind of what you need. If you start asking a little bit about some off-the-wall data, we'll see, but we can get most of the core kind of things that we need to look at. The last program requirement around quality improvements, this must have the opportunity to participate in QI activities. I know a lot of you out there already do your own quality improvement work within your departments. It's been part of the maintenance of certifications for faculty for a while. So this is something that is happening. So they do have the opportunity. For instance, there's interdepartmental activities, there's the research around QI. Residents are we look for representation from every program on our Resident Quality and Safety Leadership Committee, where we do QI projects and QI methodologies, and we go more in depth into QI education. So there's that opportunity, as well as we have a couple of residents and fellows on our Quality and Patient Safety Subcommittee. So there's options and opportunities out there for them to be involved in, and if you find that they want to be involved or you need that involvement to meet some of your goals, the opportunities there, just reach out and we can get them involved. So when we look at health disparities, so I wanted to drill down on this a little bit because this is a big thing that the ACGME is looking at, that we need to be aware of so that we are prepared when we do site visits or when we do have a CLEAR visit. And this report, the current state from the ACGME is really few clinical learning environments have strategies for addressing disparities. It's really uncommon for leadership to identify quality improvement areas around them, and there's just a lack of data. There's a lot of focus on specific issues. There's a lack of population understanding. For instance, sometimes when I go out and talk about this, the response is our door is open to anybody. Well, sure, it is, but we need to have an understanding of what that means for the patient population we see and how that compares to the care being given across the board. And so a big example of that right now is around the vaccine outreach, right? And some of the issues that we've seen around the health disparities in our local community. And so getting that data, that's a big, actually, QI project I've been working on lately, is how do we get that outreach into the underserved areas and ensuring that they're meeting the needs of the population and not just focused on one population or the other. And it's been a big kind of opportunity to do that, and everybody's struggling with that. When I talk to other institutions, they've all met with the same issues, and this really is a clear example of what the ACGME wants to see in our residents having an understanding of that disparity and ensuring that the care delivery is across the board equal. And so they came out with kind of recommendations of where they want us to be, where they want the ACGME wants us to be in the U of L. They really want education around health disparities and healthcare disparities. They want to know what the site's priorities are in addressing them and what things the institution is doing to put into that. Educate trainees on identifying and eliminating them in certain populations. How do they inform clinical sites for identifying them? And then data feedback, as always, is a big thing in getting that data. So part of this is just getting through some of this and getting that data and getting the information to the residents. I know this is going to be something that I'm working on from our hospital standpoint, and getting the hospital leadership involved in this and understanding how can we get this information and education. We can educate all day long, and I think that we have the availability for that. But getting you that information back is going to be something that we need to do, and need to provide, so that you can then better understand what your care is and you can convey that to the residents and fellows. That being said, I think this is going to be an issue, and something that will continue to be addressed. So hopefully when we do talk to the ACG, we can say, yes, we're aware of these issues. We're working on doing this, getting data back, getting an understanding of our healthcare and what we're doing for our patients. And this is kind of the big clear pathways to excellence. If you want to read more in depth on what they found or what their guidelines or their suggested improvements are, this is where to go, and kind of read about that from their pathways to excellence. Okay, that kind of wraps up the common program requirements. Those big things that we need to meet, and have some sort of way to address them or say that there's work being done. I encourage all the programs, when you're going through your web ads and you're going through your program assessment, there's no reason not to say in there, hey, we recognize that this is an area of improvement and this is what we're working on to rectify that or to become better in it. Having that recognition, I think, for the ACGME is great. They will say, okay, good, this program understands that this is something that's needed, and they have some sense of or an idea of how to address it and work towards it. And then that's where those kind of every year, as you're reevaluating where you stand or reevaluating where your program lies, you can say, hey, we're doing a PDSA cycle on our healthcare disparities data. And, we got to this point, now we need it more granular, and we got to this point, or we're doing this outreach to a population that we recognized was underserved in our data, et cetera, et cetera. So I know you don't have a lot of room for a lot of explanation, but it's there to say, we recognize it's an issue, and this is what we're trying to do to fix it. So switching gears a little bit, some of the feedback that we've received from programs and residents is residents are clamoring and wanting more and more feedback, right? A lot of residents seem to want more of a real-time assessment on how they're doing than more of a kind of 3 months later, they're getting feedback for what they did 3 months ago. And for me, I remember residency, it was like, no news is good news, right? If you didn't hear you were a problem, you aren't a problem. And for me, I heard I was a problem a lot, but so at least I knew. But back then, it wasn't a lot of daily feedback. So what we wanted to do is we wanted to try and figure out how could residents get that feedback more on an on-demand type of process. And so how do we do it when residents want it? How do we do it to make it easy on the people doing the training to do it? And so that's where we're looking at a new thing, and we're ready to kind of get it implemented and do it in a couple of pilot processes. So to address it, we developed a quick 3-question evaluation. We got it incorporated into MedHub so that it would be an easy thing for programs to track, easy thing for give the residents feedback, and they could access it. You can access it versus the web or the MedHub app, and I'll show you kind of what that looks like on both sides. And it's something that you can do, that the residents can do as an on-demand feedback. So a resident worked with me one day, and at the end of the shift, I've headed out and I didn't give them, individualized feedback, or maybe they wanted some feedback on some issues that happened that day. They could go into MedHub and prompt me to do it. And it's something that's quick and kind of to the point. It's a 3-question evaluation, and then with a comment box at the bottom. So the first question, did the resident provide quality clinical care following your review today? And if you'll recognize these are the 6 aims. Was it safe, effective, patient-centered, timely, efficient, and equitable? Kind of focused in those areas. Did the resident do that today? So that resident, those 6 aims were from the Institute of Medicine, really at the focus of how to improve the quality of our care. And so you can address some of those. Number two, did anyone on your team notice a patient care quality of safety issue today? And if so, did you submit a safety report? I know that this could get kind of, you don't want to really be saying, yes, we did, and this is what we did. But this is an opportunity for people to give feedback to that resident, or to say, hey, yeah, we noticed a little bit from a communication standpoint, or we noticed that maybe a medication was entered in Cerner, we found it and we fixed it. This is kind of giving you an opportunity to say, hey, yeah, good job, we found it, or no, we kind of missed it, but I caught it. Just be aware of this going forward. And then a prompt just to get people to report a little bit more. And then this is just more of a generalized feedback. What things can this resident do to improve their quality of care based on your experience with them today? So how can you give that feedback to them and give them that kind of what the residents really seem to want is on a daily kind of at the end of the day, how did I do? And so this is the web-based. This is one of my mentees, Dan Grace, so he wouldn't mind me throwing this up here. But this is what it looks like. It's called a resident micro assessment. If you're on MedHub on the web, this is what comes up and prompts. 2 yes, no's, and then what things can they do, and then some comments. So very brief, very quick. The resident can prompt you for this evaluation, or you can go in and do it ad hoc as you want, and then it would go right to the resident. So I also did this. This is fancy today. I learned how to do screen recordings. I think my 5-year-old taught me how to do it. And so I did this on, this is my phone and MedHub app. It's really easy on the app too. So kind of talking through this, you can watch it kind of happen as MedHub app comes up. I had poor internet, finally came up, and then you can click in through this. You do evaluations, you choose a program. It's a little quick, I'm sorry. This resident micro assessment at the bottom, and then you pick which resident you want to do. These are all the residents within my program. I pick them, and then I can answer the questions. This is what's really nice for me is I can now dictate into these boxes anything I want to say. I don't have to sit there and type it out. It's an easy dictation, and I can dictate what I found, some comments, anything like that, right in these boxes, and then submit it. And really, I did this process, I learned it, did it, and this took me 45 seconds, I think, to do, and then submitted the evaluation and finished. And so we're hoping that this, for some programs, maybe it doesn't work for everybody, but we're hoping that this is an opportunity to make it easy for you to give more real-time feedback to the residents as they want or as they need, and just brief snippets for them. So with that, that's just kind of the simplistic view of that. We are looking for a couple programs to pilot it that might be interested in it. We've already had a couple programs that are. We just need to get it out there for people to use so they can give us feedback on it. If you're interested in going ahead and trying it, please just let me know. You just have to give some permissions in MedHub, and we can go ahead and get that started. Get you. We're going to work on just some papers, or not, a small packet that talks about how to do it, so that you can convey it to the residents and teach them how to go through this process, or if they want feedback, to ask. So by all means, if you're interested in doing this, let us know. But we are going to try and start piloting this in a couple programs to try it out and see how it goes. All right, getting down here towards the end. So talking a little bit about our clear visit. We're within the realm of having a clear visit. I think I just wanted to kind of make that everybody aware and make it kind of known that that is a potential thing that's out there. We are trying to do everything we can to be prepared around the clear visit, and how they would do that with COVID and such. That try and do it with virtual and asking the same questions of the residents and things, and still doing the interviews with the quality leadership and such. This would be focused, we think, this year. Well, it's always a little bit of speculation, but a lot of time this year we think that a lot of the focus is going to be around health disparities a little bit, handoffs and appropriate kind of handoffs and trainees, things along those lines. The usual kind of things that they want, but it's always kind of one year they ask one thing, and then the next year you think, oh, I'm going to show them all this great stuff we did around what they asked me last year, but they have a whole new topic that they want to talk about, and it's really for them to data gather, I think, in the big scheme of things. And then the last thing to talk about a little bit is going to be around a quality and safety departmental champion. This is just something to kind of make you aware of. Going down the road, what we found is it's a little hard to kind of reach programs or kind of reach out and give sort of what the updates are, or what the, for instance, data. If we had data and we could go to a point person, or an educational component, or if there's questions to be asked. We know that you as program directors and coordinators are busy with a lot of stuff already. And we don't want to continue to kind of bombard you with questions about how it's going and things like that. So if you have somebody in your program or somebody that is kind of your identified designee, we have one in medicine, we have one in surgery, but some, in a lot of the other programs, we don't really have that person to go to for quality and safety things and educational components. And so what I would like to do, and what our subcommittees talked about, and I think this is Dr. Roberts' idea to begin with, to his credit, which I think is a great idea, is really to identify somebody within the programs as your quality and safety departmental champion. Who's that person that's going to be kind of the bridge between the quality department and GME within your departments? As we look at what the ACGME is doing, with this kind of idea of trying to integrate departments, integrate the GME into the quality departments, I think it's going to be key to have somebody within the department that you can look to help facilitate some of these things, some of this data feedback or quality improvement projects, or even just keeping up with educational component. And so I think it would be beneficial if you had somebody to look to them as being that quality champion. And down the road, it might be that that's a title or something else along those lines to help kind of incentivize that work, because I know it is work. But I think it's beneficial, and it will be actually help facilitate, make things easier for the departments. So our subcommittee is looking for those people. If you already have somebody along those lines or somebody in mind, let us know. We'll keep a roster of those people, but it would help us kind of move forward and as we go, and having that point person to communicate with, to kind of move forward some of these projects and move forward some of the things that we want to do as an institution. So with that, I've actually wrapped up a couple minutes early. I wanted to leave time for any questions at the end. Hopefully this talk gave you a little bit of some of the things that are key components, things that we need to address, how we're addressing some of those, as well as some of the work that's being done around it. So open for questions. If you want to type them in the comments, or if you want to speak up, happy to answer anything. Well, okay. Usually these Zoom meetings, it's a little awkward when you just, the silence. Usually when you're in person, right, you can at least stare at people in their eye and make them ask a question. They feel awkward enough. Oh, there's Laura. Hey, Laura.
There is one in the chat.
Oh, okay.
Asking about a copy of the slides just on the RL solutions.
Yes, but I can. We can get that to you, and we can actually put that up on MedHub as well as get them sent out to you. I have I can get those slides, and we actually have a set of training slides that we can send to just for help. All right. Well, thank you everybody for the time today and for listening. Thanks for being. If you're not interested in quality and safety, please thank you for being receptive to it. It's my passion, but I think it's great. So if you ever need anything, hospital side or GME side, please reach out to me. I'm always want to help you and help make it easier for you to do the great job that we're doing every day. So thank you very much, and I hope you enjoy the rest of your day.